Hello and welcome to today's webinar. I am Trevor. I'm the Communications Manager for the Canadian Cancer Survivor Network. Thank you for everyone for attending for today's webinar. This continues our spring and summer leg of our 2024 series. If you're new to our webinar series, a little background on our group. CCSN works to connect patients, survivors, and other stakeholder groups with decision makers and the wider community to engage in discussion and to act on evidence-based best practices to alleviate the medical, emotional, financial, and social costs of cancer. To learn more, visit survivornet.ca. Now, this webinar is being recorded and will be available on YouTube, and a link will be provided by the email you registered with, along with a link to the slides provided with this presentation. We will have a quick Q&A session at the end, but if you'd like, put your questions in the tab labeled questions on the GoToWebinar tabs on the side. And now to introduce our speaker, Dr. Jennifer Jones is the director of the Cancer Rehabilitation and Survivorship Program at the Princess Margaret Cancer Center. In addition, she is a senior scientist in Princess Margaret Research Institute and an associate professor in the Department of Psychiatry and the Dalla Lana School of Public Health, cross-appointment at the University of Toronto. Dr. Jones's most recent scholarly and professional activities have clustered around the transitional research to inform clinical survivorship care. This research platform specifically focuses on examining new approaches to predict, prevent, and manage long-term adverse effects of cancer and its treatment, and evaluating innovative models to follow up care and support. And so without any further ado, I'm going to hand it over to Dr. Jennifer Jones for her talk, Cancer Rehabilitation, What is it, Who can benefit, and how available is it in Canada?
Great, thank you, Trevor. Thanks for introducing me, and thank you for the opportunity to speak today. I hope everybody can hear me well enough and see my slides. So I'm really looking forward to today's presentation, as well as some discussion hopefully at the end, and I'm happy to answer any questions that you have or engage in any discussion around how we can actually promote cancer rehabilitation in Canada. So to start with, I'm just going to go over sort of the objectives of this presentation. To start with, I'm just going to provide an overview of why we need cancer rehabilitation, what cancer rehabilitation is, examine sort of where it fits across the cancer trajectory, provide an overview of who could benefit from cancer rehabilitation and at what stages. And then I just want to finish up talking a little bit about the current landscape of cancer rehabilitation in Canada and around the world, and talk about how we need some advocacy to increase access to this essential component of cancer care. So to start, this is just a bit of background for you. As many of you already know, many Canadians, in fact, 45% of Canadians are expected to be diagnosed with cancer at some point in their lifetime. And with our aging population and growing population, the number of new cancer cases has been increasing. But there is good news in all of this, in that cancer-specific mortality has decreased for almost all cancer types. And as a result, and in addition to that, there is also a growing number of people who are cancer survivors living with advanced and metastatic cancer, who are living longer with their disease. So they just are living more like cancer is a chronic disease with managed disease. So all of this has sort of resulted in a rapidly growing number of cancer survivors here in Canada, with 2.5 million cancer survivors expected in Canada by the year 2024. That's a projected amount. And in fact, the number of cancer survivors is increasing at 2 times the rate of new cancer diagnosis. So it is quite rapidly increasing. But there are, as many of you know, many side effects to cancer and cancer treatments that we give to people. The majority of people who are diagnosed with cancer will experience impairments to physical functioning and disability related to that. And unfortunately, these side effects often go undetected. Patients often don't report them, and as a result, they go undertreated. So cancer side effects can be thought of in sort of three different time points. So during cancer treatment, there are acute side effects that many people, almost everybody, will experience during the time that they're undergoing their treatment. So a good example of that would be fatigue. Most people develop fatigue during treatment. And so this would be considered an acute side effect, something that happens during treatment. A persistent side effect is something that, as its name says, persists after treatment ends. So going back to the fatigue example, a person may develop fatigue as an acute symptom. And for most people, we would expect that fatigue would resolve a few months after treatment has ended. But for some people, that fatigue persists and does not go away and can last for even decades after treatment has ended. And so that is called a persistent symptom or side effect. And then there are also something called late side effects, which are side effects that can happen months or even years after treatment ends. So they just come it's hard to predict when, but out of the blue, it's sort of months or years later. These could be things like cardiotoxicity, lymphedema, even neuropathies can be late effects, so things like that. All of these cancer side effects, though, can impact on a person's ability to function socially, to be able to work, and can decrease their quality of life. So this table just shows you a number of different impairments that these are sort of common impairments that patients may, cancer patients may experience. And you can see, so if we just look at pain across the first example, which is pain, so it talks about what are the causes. It can be caused by the disease itself. It could be caused by the cancer treatments we give to people. It can happen acute, so during cancer treatment. It can also persist, so long-term is persist, and then there's late onset. So you can just see that there are many acute and long-term side effects, as well as late onset side effects. And as you can see, like with the example of, say, GI impairments, for some people it can happen acutely, it can persist, and for other people they can experience onset later on. We know that many cancer survivors get through treatment and recover quite well and are able to get back to work and able to get back to their lives and transition to that very well. But there is a substantial minority of people who do experience these functional impairments that can impair all of these different outcomes that I talked about, their social and vocational functioning and their quality of life. So this was a large study. It's done quite a long time ago now, but I don't think that the findings would be any different really. Comparing people who had had a history of cancer and its treatments to those who had had no cancer history. So the gray bar are people that have had cancer, and the blue bar are people that have never had cancer. And what you can see here is that the people who had had cancer are reporting much higher rates of fair to poor health, greater than one limitation to their activities of daily living or functional limitations, and are more likely to report that they are unable to work. So I use this quote a lot actually because I think it's a really great one to talk about why we need to start thinking about cancer rehabilitation. So I'll read it for you. The experience of entering the medical system for many cancer patients is that they feel very good at the beginning, and then the treatments make them profoundly ill and often disabled. When they are sicker and more debilitated than they have ever been, they are discharged to follow-up care, which may include things like routine screening for cancer recurrence, managing ongoing medications, and others, but this does not generally include a multidisciplinary rehabilitation intervention. In effect, the medical system creates a situation where high-functioning individuals are given life-prolonging treatments and then left to struggle with how to recover from toxic adverse effects from these therapies. So rehabilitation is not a new concept. In fact, it's been around for many, many years, but it's much more established in many other diseases other than cancer. But there was a recent World Health Organization initiation called Rehabilitation 2030, in which they had a call to action to advance global access to high quality rehabilitation as an essential healthcare service for individuals with non-communicable diseases. That includes cancer. This initiative really emphasized that rehabilitation should be available for everyone and through all stages of the life course. that there should be efforts made to strengthen rehabilitation directed towards supporting the health system as a whole. Rehabilitation can be very helpful to supporting our health system and actually reducing costs, and integrating rehabilitation into all levels of healthcare. And finally, really that rehabilitation is an essential health service and crucial for achieving universal health coverage. But what was really interesting in this new report, and I think it was due to a lot of advocacy from people around the world, given the acute and persistent late effects of cancer and its associated treatment, the WHO actually called out and designated oncology as a priority initiative for a priority area for this initiative, which was really great. So what is actually cancer rehabilitation? And I'm gonna go now into a bit of detail in terms of what it is and what are the different services. And there's different definitions or descriptions of what cancer rehabilitation is. So according to the National Cancer Institute, they just have a very short one saying a process to restore mental and/or physical abilities lost to injury or disease in order to function in a normal or near normal way. And that's just really in their National Cancer Institute Dictionary of Terms. But Silver, who is a leader in cancer rehabilitation, really is the leader in cancer rehabilitation. Julie Silver has said, and I think a lot of people use this definition because it's, I think, quite a good one. Medical care that should be cancer rehabilitation is medical care that should be integrated throughout the oncology care continuum and delivered by trained rehabilitation professionals who have it within their scope of practice to diagnose and treat patients' physical, psychological, and cognitive impairments to maintain or restore function, reduce symptom burden, maximize independence, and improve quality of life in this medically complex population. So what actually counts as rehabilitation? Because I think people use it in all different ways, and actually I think we can use it in lots of different ways. So to start sort of at the bottom of this sort of staircase here, just general self-directed community-based exercise would be considered a form of rehabilitation. So people just going out, eating healthy, exercises, that's a form of rehabilitation for yourself. Community-based supervised exercise can be a form of rehabilitation, and hospital-based exercise programs are also a form of rehabilitation. And I'm going to go into what these levels are, but these would be considered sort of level 1 and 2 type of rehab. When we get into people that have more complexity, more impairments, where we need more specialized people, we're talking about level 3 or 4 level rehab. We're talking about specialized multi-dimensional rehabilitation with interdisciplinary teams, and also physical rehabilitation medicine, so the involvement of physicians in rehabilitation, and these physicians are called physiatrists here in Canada. And I've named a few people who can be involved in cancer rehab, but you can see from all these bubbles, and this probably isn't even a complete list, but cancer rehabilitation is a very multidisciplinary field, and lots of people can be involved in the delivery of cancer rehabilitation. The goal is really optimizing, as Dr. Silver said, that physical, social, emotional, and vocational functioning. And so a number of people can be involved, those physiatrists who are our physical rehabilitation medicine specialists, physiotherapists, occupational therapists, speech language pathology is very important for our head and neck patients, nutrition, and this can include dietitians. In our center at Princess Margaret, we even have a wellness chef, social workers, kinesiologists, and exercise physiologists. Certified exercise professionals can be in the community helping out, neuropsychologists, vocational counselors, recreational therapy, behavioral therapy is important, and even massage therapy for lymphedema. So I mentioned just this idea of sort of different levels of cancer rehabilitation, and this is being proposed by Catherine Afano and colleagues. This idea of sort of stepped care for cancer rehab. So not everybody needs specialized cancer rehabilitation from a multidisciplinary team, but everybody can benefit from certain aspects of cancer rehabilitation. So level 1, 2 is something that lots of people, everybody could benefit from, really general conditioning activities, And level 3, 4 is where we're talking about more a subset of patients that really need that specialized care. So I'll talk about each of these. So level 1, 2, the general conditioning activities. Really, most people treated for cancer can experience a decrease in their aerobic fitness and muscle quality. So some type of deconditioning. And we know now that there are very clear guidelines from Cancer Care Ontario and other organizations around the world who have said that all patients who are diagnosed with cancer should receive, at diagnosis, education and or prescriptive counseling on the role of engaging in aerobic conditioning, resistance training, and the benefits of exercise in general. So it used to be, not so long ago, that when people were diagnosed with cancer and going through their treatments, they were told, it's okay, just rest and relax. But now the opposite is true, really, that people should be counseled right away from the start of diagnosis to keep moving their bodies and try not to be doing just resting and relaxing, but trying to go for those walks if they can, trying to engage in sort of some aerobic and resistance exercise. And this is really important for many different reasons. First of all, it can help people get through treatment better. It can help to decrease the risk for some of those acute persistent late effects. And in fact, there's some really good evidence now to show that exercise can help to decrease patients' risk for recurrence, overall mortality. And for some people who are undergoing certain treatments, like certain chemotherapy treatments, they are at risk for things like cardiotoxicity, which is a late effect, and that can decrease the risk of those. So in general, everybody should be engaging in level 1, and that should be something that's integrated in our cancer system where everybody is counseled around that. In some cases, some people need a little bit of help to get that exercise going. They can't just go to the gym or go do their exercise at home. And for that, in that case, they may need a little bit of help from an exercise professional to provide some supervision. These could be maybe your older people or people that have some other comorbidities. But generally for them, it's safe. They just need a little bit of help. And in that case, there's lots of great community-based programs. Wellspring is one that I really like to highlight because they have online programs that are accessible to people all across Canada. So you can check it out if you want. They have many different types of exercise, yoga, all different ones that you could sign up for. There's also a program called Excel, led by Nicole Poulis-Reed, where people can sign up for online exercise as well. And these are generally run by professionals, exercise professionals that do have some some cancer experience. So level 3 and level 4 are more impairment-directed care, and really these are when we have patients that have more specific cancer-related impairments that require rehab specialist treatment. So for more uncomplicated cases where cancer-related impairments limit function but maybe are uncomplicated by other symptoms or systemic concerns, they can be treated by rehab specialists. So these can include our multidisciplinary team. So it could be occupational therapists, physiotherapists, dietitians, speech language pathologists. So they can be really focusing on the treatment of these uncomplicated impairments. And really the focus of this is to treat the impairment, optimize function, and in the end, try to get people to that level 1 and 2 where they're exercising back into the community. In some cases, some people are a bit more complicated, require, this could be where they have very problematic symptoms, they need more intensive therapy, maybe interventions that require injections, ultrasound, those types of things, or they're very complex with co-occurring impairments and high levels of disability. In that case, it's really important that we include our medical doctors in physical rehabilitation, our physiatrists, and they can help to oversee the care, although obviously the care is often provided within that multidisciplinary team with all the rehab professionals involved. And again, the goal of level 4 is, again, to get people feeling better and back to that level 1, 2 when possible. So where does cancer rehabilitation fit into the cancer trajectory, and who can benefit from this? So I think I've talked a little bit already about who can benefit, which is basically everybody. When we talk about the cancer trajectory, there's sort of different stages or times across when somebody has cancer. First of all, obviously there's symptoms that people may experience that bring them to the cancer center for diagnosis and staging. They then have treatment. For some people, that treatment is the goal of that treatment is to cure. In some patients, the treatment is really to manage the symptoms and manage the disease for as long as possible. And then people go into sort of, when we talk about a survivor, we're talking about everybody from the point of diagnosis to the point of death. But when we talk about survivorship care, we're often talking about sort of this gray point where people have sort of done their treatment. They're in this follow-up phase. But there's also, as I mentioned at the beginning, a growing number of people who are considered survivors who have sort of managed chronic or intermittent disease. So their disease may come and go and they get treated. And so there's this phase here. And then some people may have a recurrence, a second primary, come back into the cancer system. In other patients, unfortunately their disease progresses, in which case they'll receive palliative care, and then there's death. So when we talk about cancer rehabilitation, though, cancer rehabilitation actually can be implemented throughout that cancer trajectory and the cancer continuum, from the point of diagnosis, really. So as I mentioned, at the point of diagnosis, patients should be counseled on the role of exercise and the importance of exercise and the benefits of it, and that should be happening to everybody. For some people, there's also something called rehabilitation, which I'll talk a little bit about, and can be helpful for some patients who are about to start treatment. And then there's restorative and supportive rehabilitation that can happen during and after treatment. And for those patients who are palliative and closer to the end of life, they're often provided with palliative rehabilitation. So occupational therapists, physiotherapists can be helping patients at home or in our palliative care units to keep their function up. So in terms of rehabilitation, certainly everybody can benefit. Everybody could benefit from rehabilitation. The idea of rehabilitation is really to, before people start their treatments, to optimize their function. So get them really conditioned so that they can weather that treatment as well as they can. And really the goal is to improve their recovery so they recover faster, but also optimize their treatment tolerability, which means that they can get through their treatment. So for example, with chemotherapy, when people are in really great shape and are exercising throughout, we know that they can withstand their chemotherapy and actually get more treatments in. So that's sort of the goal of rehabilitation. Also, there's a great rehabilitation program here at University Health Network within the surgical program. So patients pre-surgery can take part in a rehabilitation program, and it just helps to condition them up before their surgery and helps them with that recovery. So as I mentioned, everybody could benefit from rehabilitation. Currently, it's not standard of care or offered to everybody. And certainly I would think that everybody should, though, be getting that recommendation that they should be keeping as active as possible leading up to their treatments. But there are certainly target groups that I think really do need more direct intervention. And those can include those people who are frail, who have comorbidities or in poor health. And that's identified even before they've started treatment. And that's actually quite a lot of people. And those people could really benefit from some rehabilitation, like focusing on that exercise, nutrition, managing stress, those types of things leading into their treatment. Rehabilitation usually involves these multidisciplinary interventions, like I said, with that physical conditioning, exercise, nutrition, and psychosocial counseling. And you can see here the idea with rehabilitation is that during this phase, prior to, say, surgery or chemotherapy, you can see on this bar here, people are conditioned up, so their exercise, their fitness levels are getting higher. And then during treatment, everybody will experience a dip in that, but the dip is not as significant as those people who did not have rehabilitation. And you see that their bounce back in terms of recovery and survivorship is much faster and greater compared to people without rehabilitation. So that's the idea of rehabilitation. What we consider more sort of traditional rehabilitation is really more the reactive rehabilitation. So the idea of reacting to people's symptoms or things as they develop them during treatment or after treatment. So this is more impairment driven. So as people develop symptoms, they are offered rehabilitation. And again, this can happen. Restorative is really more during, supportive is after treatment. And cancer rehabilitation really at this stage is very similar to what you might see in other conditions. So it involves, again, physical using exercise, nutrition, self-management skills, focusing on psychosocial health. And it usually takes a very holistic approach, looking at all of these together rather than each symptom separately. There are lots of different interventions that can be offered through rehabilitation during the restorative and supportive care, time periods. And it really depends on what the impairment is that is presented. And they are delivered by different rehabilitation professionals, depending, again, on the issue that's presented. So if a person presents with an issue around cognitive impairment, they would likely see a neuropsychologist. If it's a patient that presents with functional mobility or musculoskeletal impairments, they would likely see a physiatrist or a physiotherapist. So it really just depends on the impairment who they may see. But a big part of cancer rehabilitation and survivorship in general is the focus on self-management and really teaching health promotion. So for 99% of the time, or even more, almost all of the time, people are at this point back at home and not coming into the cancer center very often. And so really they're having to learn these skills and learn how to manage these symptoms, learn how to do the things that they need to do to make themselves feel better. So there is a big focus in cancer rehabilitation on trying to teach these skills to people so that they can embed them into their lives. And the boxes here are just some examples of different issues and impairments that could be addressed by cancer rehabilitation, but this is by no means an exhaustive list. And then supportive rehabilitation can also include individuals living, sorry, this shouldn't say individuals living with people, but should be individuals living with slowly progressive disease or chronic malignancy. So these are the patients that may have advanced disease that's sort of managed by treatments intermittently or ongoing, or chronic malignancies, which are more likely with hematologic malignancies. So this historically, cancer rehabilitation hasn't really been offered to this population, but more and more now there's recognition that this is a population that can absolutely benefit from rehabilitation. With the focus on maximizing people's function, their independence, and their participation in activities, and trying to promote quality of life. So the focus here is a little bit different from those patients, obviously, who have finished treatment and are sort of at that recovery phase, where we're focusing on promoting recovery and getting back to their lives. In this case, patients are dealing with their cancer ongoing, and so the focus is really on that promotion of function and independence. Again, it's all the same types of approaches that we would use with patients who are post-treatment, so focusing on that physical activity. Nutrition is a really big issue, managing stress, and then also learning all those self-management skills and compensatory strategies to increase their self-care, and also in order to accommodate the different impairments that they may be facing, and also teaching in advance some of the skills that they may need to manage symptoms that they may experience from ongoing disease. So the final thing I wanted to talk about is sort of, now that you have an idea of what cancer rehabilitation is and sort of what it should look like, I want to talk a little bit about where we are now and the availability of cancer rehabilitation here in Canada. So this is sort of a more general, not specific to Canada, but first of all, there was a nice review recently done by Nicole Stout, who looked at oncology guidelines around the world, all the different oncology guidelines, to see how many of them had integrated cancer rehabilitation and exercise recommendations within them. And they found actually like just under 40 of the guidelines that they reviewed had actual explicit recommendations regarding cancer rehabilitation. So many of these guidelines, these are just general oncology guidelines, are now including recommendations for cancer rehabilitation referral and interventions. which suggests that rehabilitation really is recognized as an important component of oncology care. But I should mention that there are currently no comprehensive specific rehabilitation guidelines or clinical pathways for cancer care that have been developed. And I think this is a gap and something we need to do. The availability, despite the fact that there's all these recommendations saying that patients should get access, have access to rehabilitation, and exercise should be a big part of what we do in cancer care, the availability of rehabilitation services for cancer patients remains quite limited in most countries, including Canada. And it's estimated, depending on which paper you look at, some have estimated 1 in 200, others have said 9 in 100, but very few patients are actually getting access to cancer rehabilitation services. And I've just highlighted that these gaps in access have significant consequences, as timely and appropriate rehabilitation can improve people's functional outcomes, reduce symptom burden, and enhance a person's overall quality of life. So in Canada, where we at, it's not really that much any better. Comprehensive cancer rehabilitation programs are still really the exception in cancer care in Canada. It's estimated, and this is a little bit of an older statistic, but there's about a couple dozen sites across the country that offer some form of cancer rehabilitation. So there's certainly, like, within inpatient units, there's occupational therapy, physiotherapy, and most hospitals have some speech language pathology access for their head and neck patients. But in terms of comprehensive cancer rehabilitation, there are very, very few programs available in Canada. And in terms of physiatrists, who are the medical doctors that offer rehabilitation, there's less than 10 physiatrists in Canada who specialize in cancer rehabilitation. But the good news is that Princess Margaret has a fellowship program for physiatrists to go through to become specialists in cancer rehabilitation. And this has been going on for several years now, and we generally have 2 to 3 fellows coming through our program, which has helped us to increase capacity across Canada and around the world. And in fact, one of our fellows, Dr. David Lonchelaire, who was actually one of our first fellows who went through the program, has and then stayed on as a staff member with our team for several years, has now moved back to Calgary and is starting a second fellowship program there in Calgary, which is wonderful. And hopefully this will result in more physiatrists in Canada being able to help run and supervise cancer rehabilitation programs. There's a lot of different causes for why access to cancer rehabilitation in Canada is low. And these are a few of the main ones that I've highlighted. So first of all, the biggest issue is funding. So right now, the funding structure of cancer care across our different provinces remains very much focused on acute care. So our funding for cancer has really pretty much stayed the same over the past many decades in terms of focus really on the diagnosis and treatment. And this has not shifted in any way in response to the fact that there's this growing number of people who are actually surviving cancer. So it does not currently include outpatient rehabilitation for patients who have undergone treatment for cancer. When there is funding available, so an example is here at Princess Margaret, we do have a cancer rehabilitation and survivorship program, a multidisciplinary team that's quite comprehensive, and we see thousands of patients every year. But we are not receiving any money from the government for this. This is fully funded through our foundation. So that is often the case, that the cancer rehabilitation services that you may see are through short-term grants, through studies, or depend on these charitable organizations or foundations to be able to provide these services, rather than getting hard funding through our governments. So again, this is a provincially organized cancer systems. The second issue, which is even if we do get that funding, there is a limited pool of rehab professionals with training and expertise in cancer rehab, and we really need to get this, change this. So this really creates a challenge when you're trying to build a cancer rehabilitation program. that is multidisciplinary when you have a lack of people that you can recruit into that program. And so as a result, what we often see now is that the services are very one-dimensional, with a focus on treating symptom impairments, just one-dimensional, focusing just on specific impairments and symptoms separately, as opposed to sort of that very holistic approach of looking at things all together. We know that most patients don't present with just one symptom. They often present with a cluster of symptoms that need to be addressed in this holistic and multidisciplinary way. And the final reason is really that even though there's been a ton of research done on cancer rehabilitation so far, there's actually more research that needs to be done. And I think it's really important that we do some research clearly showing benefits through high quality randomized control trials, but also that show the cost savings and sort of impact of cancer rehabilitation in order to justify that ask that we make to our governments. So the American Congress of Rehabilitation Medicine, which is a really big group of rehabilitation specialists down in the States. We don't have anything really similar here in that regard, but I'm a part of this research, the research task force for this. And in 2019, the ACRM created a blueprint to advance cancer rehabilitation, knowing that this is really a gap in care. So again, they proposed 5 steps, and some of these are do try to address those gaps that I just talked about. So the first one is stimulating and funding research so that we can build that research base. That's really important. And then using that research that we're getting to actually develop clinical practice guidelines and pathways for rehabilitation that's implemented into the cancer system. Increasing clinical capacity by educating more cancer rehabilitation providers. So we need to build that into their education programs. So for PTs and OTs, opportunities for shadowing, opportunities for placements, and we can also provide like continuing education opportunities, which we have developed this here at Princess Margaret, but there's other places many places that you can find online where there's some training available. Engaging in marketing campaigns to highlight the value of cancer rehabilitation. So really getting people aware that what cancer rehabilitation is and the benefits of it. And then most importantly, I think, is lobbying for legislative change to improve access to funding. So I just want to finish off, and I do want to leave some time for discussion, just talking about the role of advocacy and how we could actually use many of you to help us. So I feel like I'm sort of standing on my soapbox all the time, talking about how important cancer rehabilitation is and trying to get people to notice it. But there's lots of things that, and I have so many great patient partners that have become advocates in this as well. So advocacy really can take many different forms. It can be more of your sort of formal government lobbying, which is very important, and CCSN does a great job of this with their all-party caucus meetings, where they have, and many times now, brought cancer rehab to up as one of the issues that they want to raise in front of the all-party caucus. There's letter writing campaigns that can be done. Social media can be very powerful. And I think what's really important is the idea of sharing personal stories too, like bringing the human element to what we're trying to do here. So here are just some ideas of things that people could do to help advocate for cancer rehabilitation. So first of all, just contacting your local representatives. You can find usually their contact information very easily online, and just telling them that this is something important to you and that's something that you would like them to look into. And you can also, if there's people who you can identify that serve on relevant government committees like healthcare committees, you could reach out to them as well. Sometimes if you know somebody who is interested in this topic and sort of has an in with change makers, so influential people, like it's great to try to partner with those people, and I've seen that happen where it's made huge changes. Obviously, like partnering with organizations like CCSN is so important, and other healthcare organizations they can help to sponsor letter writing campaigns, voice advocacy, organize these all-party caucus meetings, really help. And so I'm so grateful to have CCSN as a partner and to be working with them to try to raise the profile of cancer rehabilitation. The idea of sharing personal stories, I think, is really important. It can really help to humanize the nature of someone's suffering that's ongoing and help to build support for that change that's needed. And so CCSN, again, has done a really nice job of this when we do the all-party caucus meetings. Generally, they bring in some people who have lived experience and who have really needed or benefited from cancer rehabilitation and sort of talked about their story and why it's important. Social media, I think, is really, I know we can get overwhelmed by social media, and there's lots of awful stuff on social media, but social media actually can be a very powerful tool to try to spread the message and try to start campaigns around why this is important. And also, even just for patients, like to be asking their doctors when they're at the cancer centers saying, you know, I heard about cancer rehab in other places. Do we have that here? And if not, why not? So the more patients that are sort of asking for this, I think it, for the oncologists and the administrators in the hospital, it starts to raise awareness that, oh, this is something that people really want. In fact, at Princess Margaret, we started out as a cancer survivorship program back in the early 2000s. And it was actually patient advocacy that started our whole program. Our program started in the breast site, and it was through the Weekend to End Breast Cancer Walk. The funders were asked, where would you like your money to go? And it was the patients themselves who said, we want a survivorship program. And so because of that, that's what started our program. And it was really the patient voice and the patient need that drove the development of our program. So I just want to finish off with two quotes. So I'll finish off with sort of my final statement and then a couple quotes. So I think, you know, cancer rehabilitation is at a critical stage with the number of cancer survivors in Canada expected to double by 2040. Many of these people are going to develop functional impairments or become disabled because of cancer or its treatment. However, we know that there are significant gaps in the provision of rehabilitation services for patients with cancer in Canada, and this contributes to a growing morbidity burden. We definitely need a change, and we urgently need funding for cancer rehabilitation in Canada. I really like this quote, and I'm just going to read it for you. It is challenging, if not impossible, to imagine a high-quality oncology care system that does not include rehabilitation services. Cancer rehabilitation has been reported to be an effective and efficient way to improve patient function, reduce symptom burden, and reduce resource utilization. Given that cancer patients' life expectancies are consistently shown to be reduced worldwide when their diagnosis is associated with disability, rehabilitation must be considered an essential component to comprehensive cancer care. And I want to finish off with a quote from a paper that was published earlier this year by a colleague of mine named Scott Capozza. He is a physiotherapist at Yale in the United States, but he's also a cancer survivor himself. And he wrote an opinion piece for the Journal of Oncology, the JCO Oncology Practice Journal. And this is a section in this journal where it's called The Art of Oncology Practice, where people can sort of put in these opinion pieces or you know, it's really different, not your traditional research articles. And he really talked about this idea of the concept of patient is otherwise healthy. And I'll just read this quote. While we may be living clinically with no evidence of disease, we live with the evidence of the history of our disease every day. Like petrified trees or fossilized shells, cancer treatment leaves permanent physical and psychological reminders of our cancer experience. As greater attention is being focused on the optimized management of long-term toxicities in cancer survivorship, my sincere hope is that there will be effort to educate cancer and non-cancer medical staff alike about the real physical and psychosocial adverse effects, as well as advances in treatments that will both prevent development of long-term toxicity and yield better solutions for why they do occur. I hope better options will be available to all cancer stages survivors with all stages and all disease types in the not so distant future. I am okay, really, but I'm not sure otherwise healthy really applies to me. So I'd like to finish there, and I'm happy to open it up for questions or discussions. And thank you so much for your time today.
Excellent. Thank you so much for the presentation. It was very eye-opening, and we do have quite a few questions, so we'll get right into it. Angus asks, do you find that rehab focuses on several specific areas, i.e. lymphedema for breast cancer patients?
Yeah, so thanks, Angus. Hi. There's definitely some cross-cutting symptoms that people will experience no matter what different disease they have. So fatigue is one, lymphedema you see across many different disease sites. Pain can be something, but then within each disease, there can be some specific impairments too. So for example, in breast cancer, we may see, sort of like shoulder impairments as a result of their surgery or radiotherapy. In lung cancer, it can be dyspnea. In head and neck, it's more, some of the swallowing and speech issues. So there can be specific impairments related to the disease processes or the treatments that we give to people. But then again, like I said, there can be cross-cutting impairments. And as I mentioned, a lot of these impairments happen in clusters. So you often don't see somebody that comes in with just sort of one thing, like lymphedema. They often will come in with a whole host of different things, which is why it's important to have that sort of multidisciplinary and interdisciplinary multidimensional approach. I don't know if that answered your question. Hopefully it did.
And yes, another one from Angus said some recent American work showed that less than 30% of cancer patients meet the American fitness guidelines of 1 of 50 patients. Would that hold true in Canada? And how do we increase awareness of this need directly to patients?
Yes, thank you, Angus. That's very, I think, very applicable to Canada too. I would not expect the statistics to be any different, honestly. So it's true that cancer survivors, many cancer survivors and patients are not engaging in sort of guideline adherent physical activity levels. Again, that's really why I think it's so important at the point of diagnosis that that message is coming through and that supports are put in place to help patients with that engaging in physical activity. But, it's a lot easier said than done. For somebody who's never exercised before in their lives, asking them at a time when it's like so stressful for them to have just been diagnosed with cancer to now like start exercising can be really, really daunting. And so that's why, having supports in place to help with that is really important. But also, somebody doesn't have to necessarily meet that 150 minutes of exercise a week to get benefits. So, that's what we're going to strive for. But even just getting off the couch and going for a walk around the block a couple times a day, moving your body a little bit more is better than nothing. So I think that's really the message that we should be saying to people. But we definitely need to have some supports in place to help those people who want to get going and are having a hard time doing it. So yeah, I think it's definitely a gap. There's lots of people that, we need to help.
Excellent. Judy asks, does this have to be done province by province effort? I'm assuming that she's talking about advocacy and expanding different rehabilitation centers.
Yeah, so so our healthcare system is, the cancer care system is organized provincially. So each province funds their cancer system. So it kind of does, although I do feel that if you had one province start doing it, hopefully it could result in sort of a snowball effect where people say, well, why do they have that here in Ontario or in BC or in Alberta and we don't have that there? So I think, we do have to work provincially, but I think there could be national advocacy, like just bringing the awareness to it and then working with your provincial agencies around that.
Excellent. Chris asks, you focused on publicly funded rehab. So some disability insurers do better at providing appropriate rehab, return to work / stay-at-home work services for cancer patients eligible for those benefits. Do you have guidance for insurers for benefit plan members with cancer and comorbidities?
That's a great question. So definitely people do have private insurance. Some people have private insurance coverage through their employers. And if they're able to access care closer to their home with somebody that they feel comfortable with, that's wonderful. I don't think there's any clear guidelines for insurers at all around that. I think one of the other big issues that we encounter when we suggest that to our patients is that the capacity or a lot of practitioners in the community do not feel comfortable working with cancer patients or do not have that expertise. And so that's really where we need to build on that capacity, not just for interdisciplinary and multidisciplinary teams within cancer centers, but we need to build capacity within our communities too. So helping to build training so that people can go to their physiotherapist or occupational therapist or exercise physiologist at the gym near their home and have somebody that has that expertise. Right now, that's really, it's really not available.
All right, and a kind of almost a follow-up question to that. Are you, from Al, are you aware of any offering in Ottawa?
Oh, well, I think there's the Maple Soft Center that has some programs. Also, you can, in terms of community-based programs, there's also access to Wellspring. In terms of rehab itself, I'm not aware of a cancer rehab program in Ottawa.
All right, a couple of questions from Adrienne. First one, will our oncology team be aware of this rehabilitation program if I bring it up?
Well, maybe or maybe not. I mean, we have a rehab program here at Princess Margaret. I would hope that if you are a patient at Princess Margaret and you bring it up, that they would be aware, but it's possible that they're not, and we know that that's probably the case in some situations that they're not. If there is no rehab program in your center and you ask for it, they're probably not going to be aware of it because it's not there, but I don't think that that's a bad thing. As I mentioned, I think it's important that we're asking for these things. And the more that people ask, the more it's sort of, when people start demanding things like, I need this, I need this to help with my recovery. I think that then when we're presenting in terms of our, even just our hospital executives and things like that, there's a lot more buy-in in terms of the importance of it. And the oncologist can also advocate for the funding for this as well.
Excellent. And again from Adrienne, can proactiveness be part of this as well? Like if you know it will affect your eyesight, should we go through Braille training of some sort? Same with sign language if we cannot talk down the line.
Yeah, absolutely. I mean, I think we can be much more proactive about things. I think, a lot of that is, that idea of rehabilitation really is about being proactive. It's not about being reactive. So it's trying to prevent things. But also, if you know that, a certain treatment is going to result in a certain thing and there's nothing you can really do about it, we can be proactive. So an example that we do, I think, a fairly good job about is fertility. So we know that, some of the cancer treatments that we give to people in our young adults will result in them being infertile. And so the idea of egg or sperm banking beforehand is really important. But we could be doing that for other things too. If we know that it's going to result in a disability that is sort of something that we can't prevent.
Lori asks, is there a cancer rehab for metastatic patients in Southern Ontario? I thankfully have been metastatic for 9+ years and we are constantly having treatments, and though they're keeping us alive, the toxicities are getting worse.
Absolutely, absolutely. And I know, and this is what I've tried to highlight. And we at Princess Margaret, we started seeing a lot more patients coming through our program that had that were the same as you, Lori, with metastatic disease for many years, sort of ongoing treatments. Obviously, as a result of that, there's just so many symptoms, so much burden from those treatments, and they can absolutely benefit from cancer rehab. In fact, probably a really high priority population that should be all getting rehab. But unfortunately, in Ontario, there is probably, there are very few programs like that. So you could certainly, if you're a Princess Margaret, you absolutely could. We see lots of patients like that. You can be referred to our program. If you're outside of Princess Margaret, I think Sunnybrook has some services, but if you are in sort of like, I think in Hamilton there are some services actually. Outside of that, I'm not really aware of anything else.
And actually, just as an aside from Al's question, Donald Windsor in the question said that Beth Hogue is a physiotherapist in Ottawa who specializes in cancer patients. One of the things that I kind of noticed, though, Jen, as a trend for a lot of these questions is that it seems that there are experts out there, and a lot of them can deal with cancer rehab. But it seems as, again, like there are certain people are aware of certain people, but there's also a lot of blind sides. So is part of making cancer rehab kind of standard across the board, anywhere, but talking about Ontario, is to kind of, does there need to be like a database of physicians as part of rehab so that they can, so that a system like this can work more efficiently?
Yeah, I think that would be great. Like, you know, starting out just having a list of where the programs are and who would be eligible to access them would be great, or services like physiotherapy or massage therapy or things like that. And I think, you know, when you're making those kind of lists, though, of professionals in the community, we have to think about, you know, what makes somebody an expert. Just because they say they're an expert, like, do they have specific training, those types of things. So I think we would need to sort that out, but I think that would be a wonderful resource for people, absolutely. I do want to caution, though, like, you know, I think, you know, if you have insurance or you have the financial means to pay for private services, that's wonderful. And if you can find somebody that has trained or feels comfortable, and you're comfortable working with, that's wonderful. But there are a lot of people that is not an option for. And so, you know, the idea that, you know, we actually really need some publicly funded services for patients. And certainly for those people who have those very high levels of impairments, that should just be part of care in the cancer system.
All right, excellent. We have time for one more question. Adrian asked, regarding the management of side effects, will there be someone in the rehabilitation team to advocate for some of the medicine to be covered that are not covered by insurance, for instance, for drowsiness, nausea, mouth sores, pain, etc.?
Yeah, I'm not so familiar with that. I haven't really encountered that where medications that say our physiatrists or whatever are prescribing are not covered. Generally, they are. If it's over the counter, maybe it wouldn't be, but feel free to follow up with me because I'd love to learn a bit more about that. Because yeah, definitely, I mean, all of this, and I know CCSN actually does quite a lot of work around advocating for medication coverage and things that are currently not covered. So that could be another thing we could put on our radar and our wish list.
Yeah, absolutely. Especially considering take-home cancer drugs, they're such a key part of the cancer care regimen, and they are not covered, or they're not administered in the same regard as those that are done in hospitals. So it's definitely something that we are going to look at as well. Well, Jennifer, thank you very much for your talk. It was very eye-opening, and we really do appreciate you coming here and talking about this very essential service. So thank you very much for your presentation.
It's my pleasure. Thank you so much.
Excellent. And now this is one in a series of webinars that we are presenting this spring and summer. Next one is happening in another 2 weeks. It's about vaping and cancer and the links of where we are connecting those so far. So to stay in the loop about webinars, visit our website or check your email for our e-blast. If you're not seeing the email in your inbox, check your spam folder because we do use a third-party email service. And if you're still not doing that, make sure you are subscribed to our newsletter on our website, so we don't miss about what you're doing here at CCSN. If you want to see all the webinars, you can go to survivornet.ca/webinar or go to CCSN YouTube channel. You can find all of the webinars there. And so with that, I want to thank everyone and Dr. Jones for everything, and I hope everyone has a lovely day. Ciao for now.
Great, thank you.